About 3% of all term pregnancies, baby is found to be in the breech position. Now, let's talk all about it, including external cephalic version, how we might help baby turn from a breech to a head down position, along with a bunch of frequently asked questions regarding breech and ECV.
And I didn't mention that we'll actually have live video of an actual ECV, so stay tuned.
Welcome back to the Expecting series. When it comes to you and your pregnancy, you deserve reliable information. With that being said, my name is Eric Schmidt. I'm a board-certified OBGYN, and let's talk about breech, ECV, and how we turn babies from breech to head down. When we talk about baby's position, or what we call presentation, or the part that's presenting to the cervix, because that's where baby's going to come out, and it matters. And we might use terms like breech, which means baby is butt down or feet down, or transverse, meaning baby's head is from maybe one side or the other and goes across, or what we routinely like at term is head down or cephalic or vertex. We can actually break breech down into a number of different other subcategories. Those would be frank or complete or incomplete. Now, I remember frank because I'm not like Frank, and so I can't put my feet by my head. So in frank breech position, baby is with their own feet by their head, meaning their hips are flexed towards the body, knees are extended. And the complete breech position is when baby hips are bent, knees are bent, so they're kind of in that cannonball position. There's also a subcategory called incomplete breech, which that would be baby might have one of their legs or hips is not flexed and is more of a footling position, or it could be both. And the footling category would be in the incomplete breech position. So often patients are asking, well, how does this happen? How do I know if this might happen to me, or why did this happen to me? Why is my baby breech? Let's go over that question, because there are a couple of risk factors someone may have that leads their baby to be breech, but often actually there might not exactly be a reason. So some common risk factors that might increase someone's chance of their pregnancy being in breech would be if the uterus has an abnormal shape to it. And so someone might say, oh, I have a heart-shaped uterus, or I have a septum uterus, bicornuate uterus. Those babies, because of the abnormal position or the little dividing membrane, would have a higher chance of your baby being stuck in the head-up position. Other things that may do that is if there's too little amniotic fluid, or if there's too much amniotic fluid. Also, multiple gestations, or what often referred to as twins, triplets, there's a higher chance that one of those babies, because of the limited room, might be in the breech presentation. Let's go over another question. Can a mom actually tell if their own baby is breech? And yeah, you might be able to. For example, as baby is growing and you're getting into your later third trimester, baby's head should have more of a prominent, hard, solid feel to it. And so if you're feeling that hard, almost softball size feeling up by your ribs up here commonly, that could be the head. Make sure to tell your doctor you feel like, this hard part feels almost like a head would feel. Let's check with an ultrasound. Or someone might feel more of kick or flutters by their cervix. Now, this could also be showing that baby might be in that footling breech position if those kicks are really happening down by the cervix and the pelvis versus up more in the upper quadrants of the abdomen. And of course, the best way to tell would be with an ultrasound. And this can be as simple as just at a quick little visit with your doctor. Often for me, if a patient doesn't already have an ultrasound to check growth or for another reason around 36 weeks, I would be doing not only palpating with my hands or feeling with my hands to check baby's position, but confirming usually with an ultrasound if there is any doubt, just there at the bedside. Another part to clarify, and I do see some patients who worry about this once in a while, is if they're getting their 20-week ultrasound or 28-week ultrasound. At this point, it doesn't matter baby's position. They're able to often freely move from one position to the other. There's lots of amniotic fluid. Baby isn't so big yet. And often we are seeing babies in breech position or presentation at that point in time. So don't worry if your baby's in breech at that point in time. They have plenty of time to change that getting into the mid to late third trimester. Really, it's around that 36 week mark where we're really checking, making sure baby's in the head down position, so we still have time to potentially adjust that. So we're about to get into the different ways in which we can potentially, hopefully, change baby's position to a head down. And you might be asking yourself the question, well, why does it even matter? And so let's go over that real quick. When we're looking at delivery of a baby, especially a vaginal delivery, the head of the baby is usually and should be the biggest part. That's the biggest diameter. And so when a baby is coming through the birth canal and that head is coming through the birth canal, it's kind of paving the way. And so when that head is starting to come out and you're about to birth your baby, that head is the biggest part. So usually once the head delivers, the rest of the body most often delivers with ease. And baby tolerates it well and better because baby is still getting their blood flow from the placenta. Now, the umbilical cord is what attaches to the placenta, and so when the head is coming through first, that umbilical cord is trailing and following, doesn't have any pressure on it, is not getting kinked usually, and it is still able to supply baby through that stressful event of labor. Now, if we look at the vice versa, if baby is coming out butt first or feet first, that umbilical cord is going to potentially have a higher chance of getting compressed because that's going to come through the cervix first, and the baby's head will follow. Again, often the baby's head is the toughest part to deliver potentially. And so if we're getting the butt, feet, legs out first, the umbilical cord is then exposed, potentially compressed. There often can be limited time where baby might get overstressed in this position, leading to decreased oxygen and blood flow. And that's why we're so concerned with breech deliveries, is because if there's any potential delay in that delivery, if you're having a difficult time delivering the head, it can be a scary situation and potentially put baby in harm's way. So taking all that in mind, including that potential increased risk of delivering breech, we give patient options, of course. So let's go over option 1. We diagnose you with breech presentation and you're 36 weeks pregnant. What do we do now? Well, if you want to do what's called an ECV, we would do that generally around 37 weeks. What ECV is, external cephalic version, meaning we're using our hands on the outside of mom's belly to try and turn baby from a butt down to a head down position. Now, this is a very safe procedure and it's a very successful procedure too. Generally, patients coming in for this procedure, it has about a 60 to 80% success rate, and there's a few factors that go into that. Generally, if someone's had babies before, the uterus is a little more pliable. It's easier and it accepts us pushing on it a little bit more. And so that's one of the positive risk factors, is if someone had babies before, we can usually more easily turn your baby. Also, we like to see that there's adequate amniotic fluid. Now, if there's adequate amniotic fluid, again, gives more baby potential room for us to make that turn. Now, of course, we don't like extremes, and so sometimes too much amniotic fluid can make it actually harder because it's just like a big tight balloon. It's hard to get your grip on baby's head and butt to really help to make that turn, so that can make it harder. A few other things that might influence whether or not ECV has a higher chance or lower chance would be if the placenta is in front. Now, again, we like to grip baby's bottom and head to help do the gentle somersault one way or the other. Now, if there's something in the way of our hands being able to hold on to baby, that might decrease the chances a little bit, so that whether that's an anterior placenta, whether that's fatty tissue, either of those things could potentially make that just a little more difficult. But doesn't mean we couldn't try. It's just a conversation we have. Okay, again, we're diagnosing this at 36 weeks, so when do we want to do the ECV? We generally want to do that around the 37-week mark, and there's a few reasons for that. Number one, as baby gets closer to their due date and after, the amniotic fluid goes down a little bit. So we talked about how the amniotic fluid can influence the ability to turn baby. We want good fluid. And so we don't want to get it to a point where the amniotic fluid starts to go down, baby size gets too big, we run out of room to have a good shot. Also, if baby has been breech, the head hasn't been putting the pressure on the cervix to help get it closer to labor often. And so it's nice to do it around 37 weeks, not wait till 38, 39, because the cervix, if baby's in breech, often isn't starting to change. And so it needs that pressure of the fetal head to have good change. And so it's nice if we're able to turn baby at 37 weeks, that gives baby multiple weeks before their due date to hopefully put more pressure on the cervix, and hopefully mom goes into their own spontaneous labor. All right, let's talk about pain control during ECV, because as you might imagine, or as you've potentially seen some videos online, sometimes we have to push a little bit hard to actually turn your baby. And so it can be a little bit uncomfortable, maybe a lot of bit uncomfortable for some. And so there are some pain control options for you. They did some studies on this and showed that potentially getting an epidural or spinal anesthesia helps mom relax, not worry about that pain, because the more the abdominal core is able to relax, the easier it'll be for your provider to potentially turn your baby. It's just a conversation you're gonna need to have, right? Because while ECV, it can be uncomfortable, and for each, it's super easy for some patients, really difficult for some. And so you could always try without an epidural or spinal because, getting an epidural or spinal is a little bit of an invasive procedure. It hurts to get one momentarily. And so, measuring whether or not you want one, it's a decision you're going to have with your provider. And sometimes we might give you a medicine to help relax your uterus, but this is often a medicine called terbutaline. It sometimes in the heart makes the heart beat a little quick, might make you feel a little heavy in the chest momentarily, or feel anxious. But this helps the uterine muscle to relax. We don't always give it, but it is an option for us to give, especially if we see that someone might be having occasional contractions, or the uterus is really contracting when we're starting to push on it. Some people give it routinely. There's a range of different potential possibilities, so talk to your provider, see what they're most comfortable with, and that's the right answer for you. All right, it's very important to talk about the risks of ECV, because there are some risks, as with pretty much any procedure or anything. And I know a lot of patients have been scared of the risks, whether it's not something they've seen on social media or read about it or heard about it from a friend. So let's talk about it. The overall procedure is very safe. If I knew a loved one that had a breech baby, I would encourage them to have or consider an ECV, because it is overall very safe. Now, there are some things that can happen that we watch out for during the procedure. Number one, when we're pushing on baby and trying to make that turn and potentially pushing and compressing the placenta, there is a chance it could stress baby out a little bit. That's why while we're doing the procedure, we often might be, trying to turn baby for 30 seconds to a minute, give or take. And then if we're successful or not, we will look to see if baby's heart rate's good in between trying. And so if by chance we're unsuccessful in the first attempt, we'll monitor baby's heartbeat, see that they're good to go. And then if we want and we have consent, we might try again, maybe a different way. There's also a very low chance of anything like vaginal bleeding. Potential pushing on the belly could cause the amniotic sac to rupture. All these risks, less than 5%, okay? The scary things that someone might think of, like causing a placental abruption, where the placenta kind of pushes off of the uterus, causing bleeding and potentially dangerous for baby, that is much less than 1%. That is like less than 0.2%. Also, anything like needing an emergent C-section, less than 1% of the time. But that's why once we do this procedure, whether it's successful or not, we're probably gonna have you stay with us to monitor the baby's heartbeat, make sure we have no concerns at all before we potentially send you home.
Okay, so here we're gonna have a video of a patient who was kind enough to consent her own experience of her ECV. And it's done by my partner, Dr. Kunachina, so also thank her for letting us post this. But again, patient consented for a video to be posted on our channel. But yeah, so this is a different scenario, okay? So this is a first-time mom. She, baby was actually head down for a little while, but then at about 38 weeks, it was found that the baby was actually butt down in the Frank Breech position. And so after hearing all of the potential risks, benefits, and her options, she elected for an ECV. She also elected to have a pain control with a spinal anesthesia, so that she may experience hopefully a more comfortable experience. And again, that is up to both the patient and the provider on how she wants to proceed with it. But that's also why you might see this being done in the operating room. That's just where at our facilities we would perform this if someone's electing for anesthesia during the procedure. So let's walk through it here. Again, so this is Dr. Kunachina, nice enough to show us this. She's trying to, with her much bigger Eastern European hands, elevate the baby's bottom out of mom's pelvis and push down with her right hand to try and get baby to go kind of in this cannonball position. Now, I think what we're also encountering in this case is that the placenta is in the front. And so we talked about how that could potentially make it a little bit more difficult to turn the baby, aren't able to grip, but also when you are pushing on the placenta, you can potentially stress baby out. And so that's also what we were observing for when you see Dr. Kundachina grab for that ultrasound, is that she is, one, checking to see if baby is moving, but two, checking to see baby's heartbeat. And so that's why we don't just try this for 5 or 10 minutes at a time without checking baby's status, because it actually turned out in this case that while doing the ECV, it actually stressed baby out. More often than not, babies recover just fine from this, and that's what happened. We tried a couple times. It was just deemed that baby would not move, or turn down to a head down position without worry for baby's well-being, and with getting a little too stressed out with the process of the ECV. And this does happen. Baby ended up doing excellent, and after some monitoring, the patient was discharged home 1 or 2 hours after this. So it's just, again, another scenario you see a lot. You Google, YouTube, you probably see someone posting a successful ECV, but this is just another potential scenario here, is that while it is about 60% successful, there are some things that we watch out for that can happen. Baby getting a little bit stressed out during the ECV that we caught, and we just had to stop the procedure and, again, explore the other alternatives. All right, guys, hope you enjoyed that video. Let's finish up the rest of the video.
There are also some potential home remedies that you could try to turn your baby also. Now, one thing would be to try the moxibustion. This is a Chinese herb, which they use it at a special acupuncture point in the 5th toe of your foot. And there are potentially some Eastern medicine people you could consult for this, or do this yourself, but burning this herb, some studies have shown, may actually help baby turn from breech to a head down position. Now, they generally recommend trying this around the 33-ish, 34 weeks of the pregnancy for 1 to 2 weeks, and seeing if it's successful. So is it something that's perfect and may absolutely do it? Absolutely not. But it's likely not harmful at all, and it might help baby turn. Also, I think potentially, often, like we talked about, babies might turn on their own from like 32 weeks to 36. So, but studies did show there might be some benefit. Also, there can be certain positional changes, like mom kind of laying in this almost head down position, kind of tilted down, trying to release that bottom from the pelvis, and in hopes that that could potentially help turn your baby. But talk to your doctor, see what they recommend, see if they have any recommendations in regards to that. Let's go back a little bit. We have our options. One, you could try these options to see if you can turn your baby to a head down position to try to have the safest, least risk delivery as possible. Number two, if you don't like the idea of the ECV, the risks associated with it, you can certainly opt for just proceeding with an elective cesarean section. Now, this wouldn't be usually right at that 37 weeks unless someone has a lot of risk factors, but usually that would be around 39-ish weeks of the pregnancy, about a week before your due date, and you can just have a C-section then, planned, scheduled. Now, with delivering a breech baby in C-sections, it can still be a little more, it requires a little extra maneuvers still to get baby out from feet first to head coming out last. But overall, again, very safe, and it is a major surgery, and so each individual person, that risk might mean something else. And so you have to just see what the best option is for you, but it's certainly within your right to, I don't want to do the ECV. I just want to head with a C-section. That is your right. And lastly, someone could potentially proceed with elective breech delivery of their baby. Now, again, this is usually only done with providers that are extremely skilled in breech delivery because of the risks associated with it. You need a skilled team. You need to fit into the very strict risk factors, and maybe we'll list those here. But those would be things like babies in a very appropriate size. There's not a lot of risk factors. Other things such as there's basically no other concerns at all. But if someone goes down that route, you just need to be very clear that you understand the risks of potentially delivering your baby breech, because there are some pretty significant risks. If you guys have any questions, put them down in the comments. I hope you learned something from this video. I hope you found it educational, and hopefully we'll be talking soon.